Welcome to the deep dive. Today we are getting into the pharmacology of, well, one of the most precise yet high-stakes drug classes in medicine, neuromuscular junction or NMJ blocking agents.
That's right. These are the drugs that cause complete temporary muscle paralysis.
And for this deep dive, we're basically translating a critical chapter from Focus on Nursing Pharmacology.
Exactly. Our mission is to take the really dense science of these drugs, what they do, how they work, and, the absolute necessity of vigilant patient care, and deliver it in a clear, practical package for you.
Okay, let's unpack this a bit. Before we get into the mechanisms, why do clinicians even use these blockers? I mean, why not just use heavy anesthesia to stop a patient from moving during a procedure?
That's a great question, and it's really the core distinction here. NMJ blockers, they give you that surgical paralysis, but without needing the patient to be in the, let's say, the deepest possible state of central nervous system suppression.
Ah, okay.
By targeting the synapse between the nerve and the muscle cell, they paralyze the muscles directly. So you can minimize the total CNS depression and, all the widespread systemic complications that deep anesthesia can bring.
So it's a targeted chemical switch instead of a complete system blackout, a precision tool.
It's absolutely a precision tool. They're essential for things like complex abdominal surgeries where you need absolute stillness, or for facilitating mechanical ventilation, and even some specialized diagnostic procedures.
Right. So to understand how we block movement, we first have to understand how movement even works. Can you start at the very beginning? How does the body tell a muscle to contract?
Okay, so that takes us to the neuromuscular junction, or the NMJ, and all that is really is the synapse, that specialized gap where a motor neuron meets a skeletal muscle fiber.
And the communication there dictates everything.
It dictates everything. Contraction lives or dies in that gap.
So what's happening at the muscle fiber level once that nerve signal arrives? How does that, microscopic structure turn an electrical signal into actual physical movement?
This is where we get into the sliding filament theory. So inside the muscle fiber, you have these functional units called sarcomeres. When the nerve impulse arrives, it releases a neurotransmitter, acetylcholine, or HEC, into that synaptic cleft.
HIC is the chemical messenger. What does it connect with?
HEC is looking for its home. It seeks out the acetylcholine receptor sites, specifically the nicotinic cholinergic receptors on the muscle cell membrane. And when HEC binds, it causes the muscle cell to depolarize.
And that depolarization is the key.
That's the key. It's the trigger that releases massive amounts of stored calcium ions from inside the muscle cell.
And what does all that calcium do?
The calcium finds and binds to a regulatory protein called troponin. Now, normally troponin is sort of a guard. It blocks the interaction between the two main protein molecules, actin and myosin.
The ones that make up the sarcomere.
Exactly. But once calcium binds, troponin moves out of the way, freeing up the binding sites. This lets the actin and myosin slide past each other, which shortens the muscle fiber. And that is the contraction.
So paralysis is just about stopping that whole cascade.
Right. You either stop ATA from starting to signal in the first place, or you prevent the muscle cell from being able to recover and get a new signal.
Fascinating. So we either block the door entirely or we short-circuit the reset button.
A perfect way to put it.
And that brings us neatly to the drugs themselves, because we have two very distinct classes of NMJ blockers that use exactly those two opposing strategies. What are they?
They are divided cleanly into non-depolarizing and depolarizing blockers.
Let's look at the non-depolarizing agents first. That's the majority of the class, right?
Yeah.
Drugs like rocuronium, rocuronium, and our prototype pancuronium. What's their mechanism?
These are what we call antagonists. You can think of them as imposters, really.
Yeah.
They're chemically similar to ACA, so they rush in and occupy the muscular cholinergic receptor site like a squatter in a parking spot.
Okay.
But, and this is the crucial part, they do not cause any activation or stimulation. They just sit there. They prevent the body's own ACE from binding and starting that depolarization, which results in a flaccid paralysis.
And if they're just blocking the natural chemical, what makes their effect last so long?
Well, they're designed to stick around. They aren't broken down by the enzyme that normally clears AG-acetylcholine esterase, so their duration is much, much longer, and that makes them ideal for prolonged surgeries.
I see.
And another key safety feature, they're hydrophilics, so they rarely cross the blood-brain barrier. That minimizes any unwanted CNS side effects.
Okay, now let's flip to the other side. The single member of the depolarizing class, succinylcholine. This one works by, aggressively overstimulating the junction?
Correct. Succinylcholine is an agonist. It attaches to the AGA receptor, and it acts just like HE, but unlike the real thing, it stays bound for a long, long time. So when you
Right.
give it, it causes this initial massive depolarization.
Which the patient actually experiences, right?
Yes, as a brief, visible muscle contraction or twitching.
So why does that massive twitch then lead to paralysis? It seems counterintuitive.
Because succinylcholine stays stuck to the receptor, the muscle cell can't reset. It can't repolarize to respond to any more stimuli. It's like leaving the ignition key stuck in the start position. Eventually, the starter motor just burns out.
The cell is just exhausted.
It's exhausted. And that leads to a final, prolonged, flaccid paralysis.
That dual action is what makes it so unique. And pharmacokinetically, I know acetylcholine is incredibly fast.
So it's the drug of choice for speed. Onset is within 1 minute, and the duration is usually only about 10 to 12 minutes.
And why so short?
Because it's rapidly broken down by a completely different enzyme, cholinesterase, in the plasma. And that short half-life is what makes it absolutely essential for things like rapid sequence intubation.
Given how powerful these drugs are, what are the main reasons they're actually used in a clinical setting?
The therapeutic indications are really clearly defined. First, they are an essential adjunct to general anesthetics during surgery. Second, they facilitate mechanical intubation. They stop the vocal cords from resisting the tube. Third, they help with endoscopic procedures. And fourth, they're used to prevent those intense self-injurious muscle contractions during electroconvulsive therapy, or ECT.
Okay, this is clearly high-risk territory. I mean, the respiratory muscles, the diaphragm, the intercostals, they're paralyzed too. What is the fundamental, non-negotiable safety rule here?
You cannot give these drugs without anticipating respiratory failure, period. They're never used without a skilled anesthesiologist or nurse anesthetist right there, ready to provide assisted ventilation, positive pressure oxygen, and immediate intubation.
So apnea isn't a side effect.
It's not a side effect. It's the anticipated action of the drug.
Let's talk about the nightmare scenario. Malignant hyperthermia, MH. This isn't just a severe side effect. This is a full-blown crisis, and it's most often associated with succinylcholine.
It is. It's a life-threatening, often inherited reaction. MH is characterized by this rapid, uncontrollable hypermetabolic state. So you see extreme muscle rigidity, then severe hyperpyrexia, or spiking fever, acidosis, and potentially death. The body temperature can just skyrocket.
So if malignant hyperthermia strikes, how quickly do clinicians have to react?
Immediately. I
Yeah.
mean, time is muscle, time is life. They have to terminate the procedure and immediately administer the specific antidote, dantrolene. Every single operating room has to have this on hand if acetylcholine is being used.
And for the patient who gets succinylcholine, because of that initial massive twitching, what specific discomfort should they be warned about after the procedure?
Right, that's a great point. Adult patients often have intense muscle pain and discomfort after it wears off, especially in their back and throat from those initial contractions. So clinicians might pre-treat them with a small dose of a non-depolarizing blocker to sort of dampen that twitch, or just give them aspirin afterward.
Okay, let's zoom out a bit. Once the patient is paralyzed, the clinical team has to maintain this very precise depth of paralysis.
Exactly. And that means being extremely vigilant about drug interactions that can either enhance the blockade or reverse it.
What are some common drugs that dramatically increase the depth and duration of the paralysis?
Halogenated hydrocarbon anesthetics, which are used all the time, and calcium channel blockers both enhance the effect. But the ones people often miss are the antibiotics, specifically aminoglycoside antibiotics like gentamicin. They can greatly prolong the paralysis.
Wait, why would an antibiotic affect the neuromuscular junction? That seems unrelated.
It is fascinating. Aminoglycosides actually decrease the amount of AC released from the motor neuron itself, so there's less native AC available to compete for those receptor sites.
So the blocker has less competition.
Exactly. It can do its job much more effectively even at lower doses. So the doses have to be significantly reduced if you use that combination.
And on the flip side, what common medications can actually decrease the blocker's effectiveness? I'm thinking about the risk of a patient waking up or moving during a critical procedure.
Well, you'd look for anything that increases the amount of native ACC. So cholinesterase inhibitors, which stop AC breakdown, and xanthines, like theophylline or imidafiline, can reduce the effectiveness of the paralysis. And that requires really intensive monitoring for any return of patient reflexes.
We also have to think about just preparing the drug.
Absolutely. You cannot mix NMJ blockers with alkaline solutions like barbiturates. They're incompatible. A precipitate will form. And it's also vital to ask about herbal supplements. Valerian, melatonin, kava. They can cause increased sedation and a much slower recovery.
Before we move on to nursing care, can we just quickly run through the main contraindications?
Of course. Contraindications include a known allergy, obviously.
Yeah.
Myasthenia gravis, because blocking more AC receptors would just severely aggravate the disease. And patients with severe renal or hepatic impairment, because they can't clear the drug, which leads to prolonged toxicity.
And you'd be cautious in pregnancy.
Yes, and in any patient with a personal or family history of malignant hyperthermia.
Okay, let's transition to the care considerations.
Oh.
This raises a big question. How does the use of these drugs vary across the lifespan? What are the unique risks at the extremes of age?
For children, it's all about careful monitoring. Non-depolarizing agents are often preferred just for comfort to avoid that initial twitch from succinylcholine. Older adults, though, are highly susceptible to toxic levels.
Because of organ function decline.
Right. Age-related decline in kidney and liver function means metabolism and excretion are slowed way down, so they need much lower, meticulously calculated doses. They also need very careful skin and eye care because of the prolonged immobility.
There's a fascinating and really critical cultural consideration with succinylcholine that's tied to genetics.
This is one of the most important warnings about this drug. So succinylcholine relies on plasmacholinesterase for its rapid breakdown. Any condition that causes low enzyme levels, like cirrhosis, burns, malnutrition, can prolong the paralysis.
Okay.
But critically, some ethnic groups, such as Alaskan Eskimos, have a genetic predisposition to low plasmacholinesterase levels.
And what's the clinical implication of that? If you give succinylcholine to someone with that genetic variation?
It means that short duration, that 10 to 12 minutes, is completely out the window. Paralysis could last for several hours, and that would require extended mechanical ventilation and life-saving care that goes far beyond the original scope of the procedure. It just emphasizes why a thorough patient history is absolutely non-negotiable.
For the nursing staff, there's one teaching point that, well, frankly, it sounds terrifying. It's the risk of patient awareness. What must the patient be told before the procedure?
This teaching is paramount because it addresses that deep-seated fear of being conscious yet paralyzed. Patients have to be explicitly warned that while they will be completely immobile, unable to move or speak, the drug may not affect their level of consciousness or their pain perception.
Because it doesn't cross the blood-brain barrier effectively.
Exactly. They rely on the general anesthetic to handle consciousness and pain. The NMJ blocker just handles the muscles.
That potential for anesthesia awareness, being paralyzed but fully aware of the surgery, is incredibly traumatic. So what does that mean for the person at the bedside?
It means constant vigilance and compassionate care. They need absolute continuous reassurance. The nurse or anesthetist has to be nearby, anticipating their needs, explaining every single sound and action happening around them, and confirming that the patient is fully anesthetized and pain-free. It's holistic care for someone who is completely vulnerable and can't communicate their distress.
Finally, what are the key implementation points for nursing care once the drug is actually infusing?
Well, beyond the constant emotional reassurance, physical care is critical. Always have dantrolene and emergency ventilatory equipment right there. Use a peripheral nerve stimulator to assess the precise degree of blockade to make sure the patient is adequately paralyzed but not overdosed.
And basic care, too.
Yes, provide frequent skin care and turning to prevent breakdown and monitor vigilantly until full recovery of muscle function, including the gag reflex and respiratory drive is confirmed.
So what does this all mean? We've seen that NMJ blockers are these precision instruments that work in two opposite ways, either blocking the ACA receptor site with non-depolarizing agents or overwhelming it with succinylcholine.
And what's so fascinating is how much the safety of these drugs depends on factors outside the muscle junction itself. Liver function, kidney function, even the patient's genetic makeup. The critical takeaway is that the clinical team is managing a drug with a very narrow therapeutic window while also managing the immense physical and emotional risks of complete paralysis.
For our listener, we'll leave you with this provocative thought. Considering that succinylcholine's short duration relies entirely on a widely variable enzyme found in the plasma, so outside the specific NMJ synapse, how might the use of these agents change if medical science could develop a mechanism for ultra-rapid targeted deactivation directly within the NMJ, thereby completely eliminating the risk of genetic variability and making the duration predictable for every single patient?
Thank you for joining us for this deep dive into neuromuscular junction blocking agents. We hope this shortcut helps you master this critical subject quickly and thoroughly.